Welcome to the Data Doesn't Equal Outcomes podcast hosted by CCNY. Behavioral health and human service organizations have to demonstrate outcomes. They have to run programs that make people better and prove it. So the mad scramble for data is well underway. But data is just numbers, outcomes are just results, and connecting the two is the work. So if it has to do with driving better results for clients using a data-driven approach, we cover it here on the Data Doesn't Equal Outcomes podcast. My guests today are Mohammad Haque, a data analyst at CCNY, and David Monroe, the Director of Evaluation and Analytics here at CCNY. Thank you both for being here today.
Thanks for having us.
All right, so today's topic is highly relevant and highly important, and it is the social determinants of health. So, David, first question over to you. What are social determinants of health, and why should we care?
Well, there's a lot of literature about the social determinants of health, but when you break it down, it's something that people have intuitively understood, which is that a person's health and well-being are affected by things beyond what healthcare provides. They're affected by their access to clean water, their safe housing, transportation, being removed from racial discrimination, having education and job opportunities, being able to speak the language in the region that they're, and read the language in the region that they live in, and having those skills to be able to communicate effectively. All of those things are the social determinants that impact health, and they tend to be larger than the healthcare determinants that impact health. There's a lot more going on. And so the healthcare research is starting to realize that they need to figure out how best to impact those things if they want people to be healthier.
Yeah, makes a lot of sense. Like you said, it's intuitive, but now it's sort of getting formalized into our healthcare system, or the healthcare system's now acknowledging it as an impact in a more formal way than before. Okay, so you mentioned what the social determinants are, a few of them, like transportation, language barriers, some of that stuff. How does a health agency who's now adept at collecting health-driven information, like how do you collect this stuff? What is a measure of transportation look like?
Well, there's a lot of different ways that health and human service organizations do this. And I'm adding human service organizations because they tend to be the ones who deliver these social determinants, not healthcare. So one of the nice things about being acknowledged by the healthcare industry is that the human service organizations have the opportunity to get paid for the work that they're done through the healthcare industry. And one of the ways that payment is looking to be taken care of and gathering data for it are through the use of Z codes is one example. Z codes are part of the ICD-10 codes. They're a standard through which people collect and categorize data for claims, essentially, in other areas. And so the Z codes were added as a way to categorize different types of social determinants and submit those for payment, for example. So there's a variety of different human services that could be paid for through that.
And so, all right, so we've got these Z codes, right? And is it true or not that you can bill for a Z code today?
It depends. And my knowledge on this is fairly new, but with some of our clients they can, and others they can't. It depends on where they're located. And in some cases, the government, some state governments have indicated that Z codes can be used, but I don't think the systems have figured out who's going to pay whom for how much. I don't think that's been really shaken out perfectly and everywhere.
Okay. So again, we have this interesting scenario where we've got these Z codes where we can categorize social determinants, right, in our systems. So, but you can't bill for them yet. You can't get paid, which is often the driver of adoption, right? So maybe I'll lean over to Mohammad here for this one. What does the collection of Z codes, if you can't get paid for them, like what's the benefit then? If you're collecting Z codes now, what does that mean for your data set so that you can apply it in a useful way?
Well, in any scenario, not just Z code, data set building and future proofing comes to mind when I think of what is the value of something to me right now. If something does not have a value to me at the current moment, I like to look into the future of what can it build? What kind of value can it bring to my organization? And if Z codes aren't implemented right now, well, it is maybe not obvious, but it is a trend that is going on that SDOH is making a impact within a lot of healthcare organizations. And SDOH data brings a lot of information and insight to these healthcare organizations. So within the future and within the near future, there needs to be standardization for these data sets. And if you take that leap, if you take that investment to gather those data, because there is a lot of data sets that are not readily collected by a lot of organizations. And so if you take that initiative to collect that data set and build out your own data set, you'll be ready for when the future comes.
Yeah, so, often we talk about collecting a new piece of data against existing. This seems like a whole new bucket. Like, what does it take to tactically implement collecting SDOH data, whether it's Z codes or some other way? Like, where do you start? What's the lift that an organization's looking at?
I think there's two main strategies you can imply when collecting SDOH data. The first one, and this one is the most common thing, is to just use census data. Census data is robust and it's pretty much updated and upkept throughout the ages. If census goes down, then something big has gone down within the federal government that you're probably not going to be worried about SDOH upkeep at that point.
So just to be clear, you're not talking about census like a program census. We use that term often. You're talking about the United States Census Bureau data.
I'm talking about, yes, sorry about the clarification. I'm talking about the United States Census Bureau. They have extensive data on a lot of social variables for pretty much throughout United States, and using that as your base of your SDOH data is excellent. And when I said there's two, I actually, when I said two, there's actually three, and continue, sorry.
I was just going to say, where can you get that? Is that data readily available? What is
that? That data is fully open for public to use. You can go to census.gov and you will have access to their API. All you need to do is apply for an API key, which takes about 15 minutes, and you have access to the full library of census without a dime. This is accessible to every single citizen and non-citizens throughout United States. Giving you a very robust data set. But there are a lot of things within the SDOH SDOH topic that aren't really available through the census data. Things like transportation is one of them, and a lot of granular information, things that really go in depth with your local state, your county, that goes really deep dive into the cultures and various variables that you want to, as an organization, want to discover. And when that comes, you have to start with data collection within your organization. So those are the two main ones, but there is a third option, which is open source data. Now, I'm a very big pusher of open source data. I love open source anything. In fact, there's a lot of things that can be open sourced, but hasn't really had the time to develop into it. One being SDOH data. And the reason I say that is because we've had an instance where we were looking at diabetes, data for diabetes, and that becomes pretty much something we have to go into open source data for us to collect. And it's not something that's readily available, but it is also something that's not upkept. Things like education data in the open source field. Your latest data set that's available to you would probably be something around 2015. You won't get the latest data. And if the individual who created that data set decides, hey, I don't want to really upkeep this data set, I have other things to do, then you're just going to be stuck with this old data. So
can I interject real quick?
Those are the three main ways. Yes, absolutely. Take it away, David.
One thing that one of our customers worked with was NewYorkState.gov data. I think it's data.newyorkstate.gov. I can't remember the URL. I'll have to look it up. But it's where New York State provides a lot of their data sets and makes them open source and easy for analysts like Mohammad to pull those data and use them. And the nice thing about it is they tell you a lot of information that Mohammad is talking about. How frequently is this updated? Who is the curator? And you can actually contact that person within the government to see what's the latest about keeping this up to date. So that's a really great resource when you're looking at the SDOH items. Some of these things haven't really been measured strongly, I think, in a way that could be used like racism. I think that is something that could be measured better.
Something as simple as like hate crime data. It's extremely rare to find, but it does exist, and there are individuals who are passionate enough to provide that data set. And this open data that we were talking about, New York State's open data, it actually exists throughout United States, and it's at a different caliber for every single state. And it's not just state; they're citywide, individual city. I know Buffalo has an open data network, which is one of my favorite open data networks, actually, because we have something as granular as individual police reports, de-identified police reports, that really allow you to build a picture, an SDOH picture for Buffalo, because things like that don't really exist throughout USA. And a lot of departments are hush-hush about their data. So access to data is very much hinges on who's hush-hush and who's willing to share and be transparent / open about it.
So in what's going to end up being the long history of SDOH data, where are we? Are we in year one? Like how, what percentage of, data and access do we have today compared to where we're going to end up eventually? I mean, how early is this really?
I feel like we're in like the adolescence years.
Yeah.
That's what it feels like to me, because before I was an analyst, I worked as a developer as well. And as a developer, I had to call APIs for a lot of different data sets, a lot of different services, and the services for those data sets and APIs are so much more robust and well-structured than anything that's SDOH related. To me, when I work with try to find SDOH data within the landscape, within the internet, it requires so much more effort than it does for any other data set, that to me it feels like we're still in that infancy, adolescence age where there's a lot to build. And there's a lot of open space for organizations to just grab at and be like, okay, we're going to specialize in this SDOH data set for all of USA, or for this state in particular. And this could provide a lot of, I feel like it could provide a lot of benefit to the state. But for them to get paid, again, as David was saying, the Z codes need to be applied and recognized throughout. And if it isn't, then it will be hard for a lot of these organizations to get fundings. So it's that feedback loop that exists.
Right. Okay. So that paints a nice picture about the technical aspects of the data. Let's talk about now, kind of bring it back down into the organizational level. So you have this picture of a geographic area in terms of, man, all that stuff that you talked about, crime statistics, general health information, pollution sources. You've got all this stuff, right? Now, how does that become useful? How can the data engineers in your world make connections from one to the other? And what types of insights can an organization gain, and how can they put them to use?
So one of our customers asked us that question pretty directly. And what we worked on was looking at gathering data from a variety of census types to get a picture of their geography and look at and use statistics to find out how impactful were these different social determinants on their outcome that they were looking to solve. And through that work, we found that there were a couple that were very strong for their population in that location. And so what we did was we created a dashboard. It was a hotspot of their geography and showed the population that they serve. They serve quite a few people, and mapped them out by density and allow them to look at those factors that impact the population they're serving so that they could see if it was an educational issue, like high school graduation might be really challenging in one area, or poverty is a big challenge in another area, or housing and access to quality housing was a challenge in another area. You could see directly that those geographies where these things were occurring, especially when multiple concepts were occurring, that they had a higher risk to a negative outcome in their life.
So what then is the translation for that agency? Okay, I see these factors, I see multiple, and I see them in an area. Like, how do I change what's an example of a program pivot or quality improvement cycle, or what's an example of potential action that the agency could then react to that to deliver a better chance of a positive outcome?
What they're working to do, and this is currently happening, is having those who coordinate care for the population have a list of the people who are the highest risk of being impacted by these social factors that lead to this negative outcome they're trying to avoid, and start working with these families and these children and youth to change the trajectory of their lives. So if you can help them with transportation, they are likely to get to the doctor and therefore be healthier. If you can help them connect with an organization that helps them with housing, they can live in a safer, healthier house that doesn't, say, have lead poisoning issues in it, and then therefore be healthier. So all of these factors are things that they're targeting through specific programs to connect them to care, and often connect them to other human service organizations to support the people that they're serving.
So in this scenario, the social determinants data helps create a risk profile, or helps identify, based on profiles, clients who are at higher risk for negative outcome, and you can direct either more or different service to that earlier. Is that a good way to frame it?
Incredible way to summarize it.
So, yeah, it seems like this is the key. It sort of unlocks the key to earlier intervention outside of just the doctor's office or the therapist's office or whatever it is. It's, hey, you're here for therapy, but I can identify these things. I know your potential risk factors. I can ask you how you're getting here to make sure you'll come back for appointment 2. And if not, I can help you. And it seems like the system's ready to embrace that and say yes. a therapist is no good if the client can't get to that session, right?
Yeah. It turns out behavior change is really hard, and behavior change oftentimes are the most powerful factors in helping people's lives. If I decide that it's so convenient to eat from McDonald's every day, I'm going to order McDonald's every single day, I'm going to get sick. And changing my behavior is really hard. So you're trying to get someone who, if they have depression and diabetes, you're telling them to change their behavior, eat differently and exercise more, but they're depressed, and doing anything is really hard. And those two concepts are swirled like a layer cake. You can't pull them apart. So you can connect that person to a nutritionist, to some counselors, and start moving the needle on behavior change so that in a year or 2 or 3, their life gets better. But often people are looking for that magic bullet, like I want to feel better next month. And I don't blame them. Sometimes people are suffering when you have those sort of things. What they have to do is trust the system, engage in their care, and slowly change the needle. One philosopher said, in order to change your life, don't aim high, just aim up, even a little bit.
Yeah.
And I think that really helps.
So you mentioned dashboarding hotspots, and like I can picture that, right? It's some kind of heat map. You're looking at a map and it's visually telling you what's going on in certain areas. Throw it back to Mohammad. From a technical dashboard visualization standpoint, like help our listeners sort of picture what they might be looking at. I think, a lot of our listeners are used to dashboards around things like productivity and discharge results, and we've seen some bar graphs and pie charts, but can you kind of try to paint a picture for us about what looking at SDOH data looks like beyond just, a hotspot map, which, that's a great first start, but I'm sure there's more lenses with which to look into it. Can you describe some of those for us?
Yeah, so definitely when you're looking at any kind of SDOH data, it is very much useful to look at it location based. Most of America is broken up into zip codes, and a lot of the data and a lot of the issues are based around these zip codes because they treat zip codes as like a group location. And when we do have a lot of these social determinants issues that are appearing, they congregate and concentrate within these zip codes. So viewing any kind of social determinants data, when it comes to viewing any kind of social determinant data, it just naturally falls under these zip codes, these area clusters that you have within any kind of neighborhood, any kind of state, city, county, whatever you have. And when you do have that, it often tends to go into any kind of heat map, because if you're looking at, let's say, crime rate, where in your city is the highest crime rate, well, you want to see it within a gradient of color. And it's easy for us humans to identify light means little and dark means a lot in layman's term. And one thing I've always not really struggled, but always put front when I'm developing any kind of dashboard and visualization is simplicity. The more data points you have on any map, the more complicated it gets. And most folks don't spend more than, let's say, 10 to 15 seconds looking at a visualization. And if you have things hidden away, half of your story just gets thrown out the window. And in that case, it's always good for me to pinpoint especially when doing any kind of map, because maps inherently are complicated to begin with versus a bar chart or a pie chart, you want to focus in on a single point. So whether it be education rate, poverty rate, crime rate, pollution rate, whatever you have, air quality is another one. Whatever you have, you want to always choose one and focus in on that in your heat map, which will allow you to get your point across much more efficiently.
So I follow you 100% on simplicity, and the more data points together, the more complicated it gets. Since we're talking about SDOH as a concept, and you mentioned a few things, right? Like rates, like crime rate. Crime is made up of many components that then becomes a rate. Are we at a place where we have any kind of SDOH indexes? Are there any, ways that we are, creating, here's your geography, and since I only want to give you one data point, I can give you like an SDOH score? Are we at a place where that's happening, or what are your thoughts on that?
In fact, I'm actually, surprisingly, I have a lot of information on this specific topic, especially the crime rate one, because for a certain client of ours, I spent a lot of time trying to find crime rate for their particular geography. And what I've noticed and what I've learned is, and this is through me sifting through all of FBI's open data, is crime rate does not exist. Crime rate is something that is created usually by the person who is creating the visualization. It is a standard that is agreed upon throughout the world of data, but it is not accurate. This is very important because all FBI provides in terms of crime data are the points. So you have 10 break-in and entries, 15 murders, and that's it. Now you, as a data analyst, have to go and find population data and your crime data and match it up based on the time that these data have been updated and create a crime rate that is as accurate as you can possibly make it. Now, this in itself just means that there's a lot of work that needs to be done in that SDOH field, specifically the crime rate field. And to your second point, which was, is there an SDOH score? Does that exist? And in fact, California, I'm not sure exactly where, had a university in California, a professor released an SDOH map where they developed an SDOH score for each neighborhood. And up in Buffalo State, somebody saw that and decided to do the same thing for Buffalo. So this actually exists for Buffalo, and the professor's name is Wendy Mix. They have produced this SDOH factor using various variables, using Buffalo's open data, and it is absolutely gorgeous. You have the different layers. I was talking about the simplicity. It's extremely simple to understand, but it is also extremely complex because it tells you the overall story in a glance, but you can go very deep within it because it shows neighborhoods and it hotspots it based on this SDOH score, which takes the overall variables that they determine to be significant and build up an SDOH score from that.
They've applied probably weights to certain elements and, it's some sort of factors. I mean, there's thought into this, right? It's not like some average or some, aggregate percentage that's easily attained. Somebody has to study all of the elements and apply severity to all of them. I mean, is that the type of work we're talking about to determine, an index or score? Exactly.
And that's the beauty of it. And I feel like having this kind of work published and out for each individual state, each individual county, each individual city would be extremely, extremely helpful for lots of healthcare providers to use and to understand. Look, you're from this area where your SDOH score is low. We could give you benefits. We can help you based on these scores, and it will allow for greater healthcare come the future, hopefully.
So how about in a predictive sense? So if you have SDOH data that tells you that that clients who come see you are from a certain area, which makes them more or less prone to certain outcomes or certain conditions, can we then watch these SDOH type indexes and anticipate that client need in certain areas might grow or decrease? Or can we not use that in this way?
What we've done is we've looked at certain factors and found that those factors based on a certain weight impact individuals' risk, but it has to be tied with other factors as well. And it turns out that those other factors plus SDOH factors together give you a full enough picture to be able to predict how likely they are to have a negative impact in their lives. At times, there are these factors that we call protective factors, that people who live in a neighborhood that is very poor, because they have a bunch of other factors that are harder to measure right now, they seem to do better. So things like a very loving family, even in the midst of chaos around you, tends to help that person do better than those who don't have it, right? So these sort of factors are really powerful, and it's pretty interesting, and I think it's a fun time to be doing data analysts, doing analytics in this area. It's there's a lot to learn.
Well, and there's always somewhere where the data breaks down, right? You can look at a zip code, you can lump everybody together, you can have indexes and scores and rates and all of that, but from one house to the next, what's happening on the inside that's immeasurable could be making all the difference, right? And that's where our job stops and the human side takes over, and we might never be able to track that.
I'd like to give a specific example, though, of where this worked, and it was very creative. So this organization was working in a whole state, and one of the things that they found is that a certain medication can, when coupled with a person having just getting overheated, could be fatal. And it was in a southern state, and what they found is that some people needed air conditioners. Air conditioners don't cost that much money compared to the cost of care. So getting air conditioners in place for these folks right away so that their internal core temperature goes down keeps them alive and helps deal with these other factors. So that it's that type of thinking and that type of creativity that's required. It's not just data, it's also being creative and taking some risk. Some people took some risk on that one, and it paid off.
So now that we're tying that thought process to the healthcare system, are we going to see a future where an insurance company says, I'll cover your air conditioner because then I won't have to cover your hospital bill?
That's one thing that I personally, as an analyst, I'm kind of scared of, is the insurance side of everything. It's like, well, your SDOH score is low, so your insurance rate is going to go up. Your SDOH, people can start using it maliciously. And I think similar to something like HIPAA, I feel like SDOH factors should be added as protected, something that's protected of an individual. That way, individuals aren't judged for their SDOH factors. But data such as your location and a lot of these SDOH data is very much a public thing, and a lot of insurance company, they have the assets to just build out those information, and without even asking for that data, they can know about your SDOH factors just through you signing up for their clause.
Well, sure. Like, I just think about myself and my car insurance. As soon as I give my zip code to get a quote, they're immediately checking the accident rates for my area and helping determine my rate, and that has everything to do with the neighborhood that I'm living in, right? Yeah.
Yeah.
I'm really interested in that, though. Can you flesh that out a little bit more? Where I know this is just sort of opinion at this point, but like, where do you think those lines are, and where do you think they should be drawn in terms of who gets the SDOH factors so they can deliver value against them, and who shouldn't have them so that they can't be malicious with them?
I feel like the ultimate goal is to remove SDOH factors, right? That's like the ultimate utopian goal of any kind of healthcare system, any kind of system in general. Because if racism doesn't exist, if poverty doesn't exist, well, those are not variables that you need to worry about. And but the harsh reality is that's like anywhere. This is not just United States. I'm from Canada, and this is happening in Canada as well. Insurance companies or any kind of organization that you want to work with have access to this and is currently using this data to file your rates. And now this is we got to get that disclaimer. This is a personal opinion. I don't think that should be the case, since a lot of things that are surrounding you are out of your control. An individual, like, I don't control the accident rate of my street, so why am I being punished for other people's behaviors, right? Similar to what you just said. And similarly, I did not decide to put up a chemical power plant near my house, so why am I being charged for health insurance premium because I live in a place where there's a factory that could probably cause me cancer down the line, right?
Yeah, I think there's a couple ways to look at it. Anyone who's doing this work can use data for good or for greed.
Yes.
And I think because we're not for profit, I think one of the things that we share as a value is we're trying to improve the lives of others. And in a way, what we're trying to do is improve the lives of those who help others and really focus in that area. So the clients that we work with, we often train them on the limitations of what we provide, the value that they have, and we are very ethical in our process to make sure that it can be used in a meaningful and equitable and just way. And I think many of our clients want that, and they want that trust. They want that trust that we are going to look at that in our process. And the nice thing about it is that that's something that we do. As you can tell, Mohammed's very passionate about it because, well, we've gained training on equitable data practices so that we can make sure that we're not accidentally harming someone. It's important. So you have to be careful.
You have to be careful. And it's the other thing is, like, SDOH data, when I said a few minutes back it's in its adolescence, I was talking about in the not-for-profit sector. It is extremely, extremely sophisticated in for-profit sectors, especially on giant corporations like Google. You know how good their SDOH data is? They know every minute detail about that just because they have the infrastructure for that, right? Or be it Google, Facebook, whatever, all the big companies, all the big tech companies, they have data comparable to, there's nothing to compare it to because they're at the top of the game.
Sure.
But because you have this lag, a lot of for-profit can utilize SDOH for their own personal gains before any kind of not-for-profit organization can come up to speed and utilize those same technology for the good side of things. And now I'm not saying a lot of these companies are evil, greedy, and only using it for bad. No, they could be using it for neutral things, right?
Sure.
Advertisement, what have you, which doesn't really affect much people, but we don't know. This is all personal opinion.
Sure.
Don't write a thesis paper on it. It's not peer reviewed.
Sure.
And
So
yeah.
I want to close by asking each of you the same question. And the question's this: if you are a mental health agency or social services agency, anything outside of the traditional healthcare, primary care, hospital practices, if you're in this sort of social care delivery and you're doing zero today with social determinants of health, what's the first piece of advice that you would give to that agency to take that first step towards making SDOH an informative part of your practices? What should that agency do first, and second or third? What are the drivers that? How does that agency raise their hand?
This is a difficult topic, but for me, I'm fairly new, but I think the thing that really drove me into the lane of SDOH when I was starting to learn analytics in general was awareness of SDOH. I think if an organization is at level zero, they need to sit down and have a talk and discussion within their organization about SDOH, bring in somebody external that has worked with SDOH data, and change your hiring practices, bring in people who have these experiences that will allow your organization to adapt to SDOH data more fluently, but not reject it, if that makes sense. Because a lot of these cases, new ideas often get rejected because they're being forced down and spoon-fed to individuals. You have to kind of base your culture around it, and I feel as though that's how I felt joining CCNY. That's the kind of culture that has been built here, and I feel right at home working with SDOH.
So the first step for you isn't even mathematical; it's education. Study it, learn it, get to familiarize yourself with it, and only then will you know how to take that second step forward. I like that. Dave, same question to you. First step for an agency that wants to bring SDOH into their practice.
I would focus on value. So one of the things that these changes bring about are opportunities, payment opportunities, potentially, and ways to use data to tell a story about populations that may be underserved. So if you look at what you currently do in the area of social determinants, and we're using that word very broadly, it means a whole lot of different things. If you look at that and find that we have this program that impacts one portion of that, let's say it's employment, start looking at telling a story about how that could potentially impact health. You don't have to prove it. You're not a scientist. Nonprofits aren't scientists, and they're not funded like scientists. So they can't prove it. But if they can tell a story that there's a relationship between us helping these folks get employment and you being able to know that you now have to pay less for their health care, then you can use that story to say, I provide a lot of value to your population. Let's talk about and think of some strategic partnerships. Think of some payment opportunities. And there's a lot of not-for-profits that are starting to do that and use that tactic as a way to have conversations with foundations, with managed care entities, and that sort of thing.
Wonderful. Well, that is all the time that we have for today. I want to thank my guests, Mohammad Haque and David Monroe. Thank you both for being here. Very informative. And I think that I sense a follow-up to this in the future. This is definitely a topic, like you said, with a lot of layers. And so stay tuned for more data analytics and quality discussion on the Data Doesn't Equal Outcomes podcast from CCNY. Thank you both.
Thank you.
Thank you.